So it's just like a conversation, but there's cameras going. Okay.
Yep.
And people will see us in the
People
podcast.
people are gonna see you.
Okay.
Yeah.
Okay.
We can always blur out your face. We kind of got off track, so I'd like to get us back on track. So what do you think about people going out, going to Mexico, going to Peru, going to these different places to be able to have that experience, which I think is a completely logical and reasonable thing to do, to be honest with you, because a lot of these people are kind of at the end of the road, right? This medication hasn't worked, that medication hasn't worked. They've had adverse side effects. They don't like how it makes them feel. They don't like to feel emotionally blunted. They want emotion. They want experience, right? And they have to choose between a rock and a hard place. So it's completely reasonable that they'd seek out, something like this to go out and do. What do you think?
So it's tough in the sense that unfortunately the underground just does not include these organizations outside the U.S. It includes people working outside the law right here in Los Angeles.
Right.
There's an very active underground here in Los Angeles.
Yeah.
And the problem is, treatments that we provide, treatments that we offer, treatments that we recommend. As I mentioned before, there's no free lunch. There's no benefit without potential drawbacks or adverse effects. And if something like this can really kind of help you, you can imagine it can potentially really hurt you, right? And so the proper precautions need to be taken. And when you're in the underground, whether it's here in Los Angeles or outside the U.S., we have no way of knowing how much screening they're doing, right? Are they asking you, have you had a history of psychosis? Do you have a first-degree relative who has a psychotic disorder? Those are the things they're actually doing for the trials right now, right? So, it's at your own risk, right? But I think if you're well informed, that you have the ability to kind of make that decision for yourself.
Yeah.
But you have to know, whatever the potential downsides if this goes south on you, right? And now I'm sure there are perfectly responsible people out there doing it.
Right.
But the what I've heard anecdotally is that with the potential advent of MDMA, a lot of these clinical trials are being run, at least here in the U.S. A lot of the folks in the underground who are kind of the more responsible practitioners have kind of moved above ground because they're now part of this legitimate clinical trial network. The people who are left over, they're maybe a little bit more motivated by profit, right? And when I've inquired about some of these underground practitioners and what they're offering or what they're doing, unfortunately, none of it looks like what they're doing in the clinical trials. So that's one thing to think about, is that when you're reading about all these remarkable outcomes, right? It's wow, these are great effect sizes. The adverse events are pretty low. And that's because it's being done responsibly. It's being done in this very controlled, reproducible, with a very reproducible protocol. There's a clear preparation. There's a clear medicine guiding session. There's clear what we call integration sessions afterwards, right? And if you ask the MAPS people, they actually believe the integration sessions actually are one of the main reasons why they've been able to keep some of these, the suicidal ideation down to a minimum. Is that for a lot of these folks, a lot of difficult things come up in the medicine sessions, and they have trouble integrating or resolving it afterwards. And without someone kind of guiding them through that, potentially adverse events might be much higher. But they have these formal integration sessions to help them with that. When I've asked anecdotally about what's going on in the underground, at least the ones I've come across, again, I don't want to make any generalizations or blanket statements, right? Because the underground is very fragmented. It's not like it's one person and they're telling you about all of it. They're just telling you about their little kind of sphere.
Right.
The preparation was minimal, right? If any, maybe half an hour on the phone. The medicine sessions were being done in group settings, not individual settings.
Right.
So what happens if you have a psychotic reaction and you have one or two practitioners there overlooking 30 people, and you decide to run out of the room into traffic?
Right.
I don't know, right? And then I asked, what are you doing for the integration? There's no formal integration. If something comes up for you, you can give us a call.
Right.
At least the ones I talk to, right?
Right.
And that looks nothing like what they've been doing in the clinical trials. So that's, I think, one point of caution, is that if you do go to the underground, you know, and if you're, the likelihood that you're getting that full model that people are doing in these MDMA trials or these psilocybin trials is probably fairly low.
Right.
And so you can't generalize, you know, the efficacy results and the safety kind of outcomes that you're seeing in these papers and extrapolate them or generalize them to kind of what you're getting in the underground.
Right.
So that,
and I think it's really important, the warning that you're giving, as well as when you take that in conjunction with the history of psychedelics that we went over. This is the exact same crap that was happening in the 50s and 60s, right?
Yeah.
Where it's leaking out of research,
Yep.
right? It's occurring in the underground,
Yep.
right? In a non-regulated way,
Yep.
right? And, you know, you could argue that, oh, that was a certain a specific time period where it was this counterculture kind of time period. But nonetheless, it leaked out, right? It became an issue. And then the government, you know,
had to step in.
Had to step in. And that's, I mean, and especially with all the positive results that we're seeing right now with the research that's coming out, right? We don't want that to happen again.
Yeah, that's a great point. So, you know, even with the 50s and 60s, it actually technically wasn't the underground, right? Because these things actually were not prohibited.
Right.
So people are just using
that's
them,
a good point.
right? They were just using them. Now, I think they started to use them in kind of outside of clinical context, and maybe some folks are maybe using them a little bit irresponsibly. But yeah, I think that is one of the major fears with the folks, especially ones that have been in the space for a very long time, is that how much do we push and how much do we kind of step on the brake a little bit?
Yeah.
We don't want to get to a point where we were in the 50s and 60s and have this thing all shut down again. We've made it this far, right? And I think, you know, they've primarily have been fairly conservative about it, right? The model they're proposing, fairly conservative. You know, that's another major question. Is all that they're providing, all the preparation, all the integration, you know, the 6 hours of prep, the 20 hours of integration, is all that necessary? Right? That's another question. But I think they're playing it safe, because they want to demonstrate to the regulatory agencies, to the federal government, to all the powers that be, that yes, this can be effective and it can be safe.
Right.
You know, you don't want to strip it down at this point. You don't want to go with the bare minimum, right?
Yeah.
Because you've got this history.
Right.
Because if it doesn't get approved, or something bad happens during these clinical trials, then, you know, maybe the FDA shuts it all down, and then, you know, you back where you are, you know, 30, 40 years ago.
But also, I don't want to dismiss people's claims that, you know, come back from these experiences that they're doing in the underground or abroad, and saying that they benefited from it. Because everything that we're talking about is rationale why these people would benefit from that, right? So certainly if they come back and they say, that was an amazing experience, one of the most important experiences in my life, and my life is completely altered after that, I think it's completely legitimate that they would have that experience, not necessarily in a research setting, right? Like we're, I think, legitimizing that experience for people here.
Yeah, it doesn't have to be in the research setting, right? I think at the end of the day, so one of the major questions is, what are the absolute essential components for safety and efficacy?
Yeah.
Do I need to have 6 hours of prep? Do I need to have 20 hours of integration? Do I need to have 2 therapists in the room? Can I get away with 1 therapist in the room? Right? Right now, you know, the MAPS people are saying, yes, you need all that. At least this is our model, right? At the end of the day, you know, you got to scale this up, right? Got to provide it to, you know, the millions of folks who are not getting better with their standard treatments. And that level of attention with the resources we have now is simply not available.
Right.
So what can we kind of like strip down? Oh, maybe we can do it with, you know, 2 hours of prep and maybe, you know, 6 hours of integration, and maybe we can do it in a group setting. And that's actually what people are doing now, right? So one of my colleagues in the VA, Chris Stauffer at Portland VA, he's actually looking at actually groups in the prep phase, groups in the integration phase, and to see if you can get the same levels or comparable levels of safety and efficacy with that model. So that way you're just able to try and treat that many more people. Right. And then, what was I going to say? So as far as, you know, so at the end of the day, I think it's not a question of like, what's the absolute bare minimum? It's going to be a question of who needs this level of like support, and who can get away with a lower level of support.
Right. And that's a big question, right? Because we're thinking a little bit ahead, but I think that's really important for this context. And that is, if this is so helpful, and certainly mental health in America is like such an issue, right? Yeah. And afflicts so many people. How would we be able to then implement this throughout the entire country and even throughout the entire world? Yeah. Like mental health is not only relegated to America, right? It's it's in third world countries and especially where traumatic events occur all over the place, right? Yeah. So how would we be able to implement this, in that sort of scale? Yeah. Right.
Yeah. It's great. Yeah. This idea of implementation and scalability, right?
Right.
Because if MDMA for PTSD, let's say this is I'm using that as an example just because it's the furthest along in the clinical development process. If this got approved, let's say tomorrow, there would not nearly be enough people trained in their type of psychotherapy to be able to deliver this.
Right.
So one question is, do you need to be trained in their type of their therapeutic model? I don't know, right? That's an open question. Yeah. And that's an interesting regulatory question because, the FDA does not regulate the practice of medicine, and psychotherapy is considered the practice of medicine. Okay. Right? So and they may write on their label, recommend that you do the MAPS model of therapy. Yeah. But physicians practice off-label all the time, right? Physicians are more than allowed to say, okay, I read the label, I understand that this is how the trials were done, this is how the safety and efficacy was when you had this type of therapist, but I don't think my patient needs that type of therapy. Right. I'm going to do a different type of therapy. Right. Now, there are mechanisms in place to prevent them from doing that, and we don't know if the FDA will implement those. It's called a REMS protocol. We don't know if that's going to happen, but yes, there are certainly not enough resources at this point in the country to kind of do it by that gold standard model. So yeah, what can we potentially kind of dial down as far as what's the absolute bare minimum? But I think at the end of the day, it's going to be having the flexibility and the choices to modify different components. Right. So it's back to this the answer of it depends, right? I know my patient; they are fairly unstable. They're prone to suicidal ideation, or maybe there's history of paranoia, maybe borderline psychosis. But I think the benefits could potentially outweigh the risks if to try this type of treatment. But because of this high risk profile of my patient, I'm going to insist on 6 hours of prep. I'm going to insist on 20 hours of integration. I'm going to insist on having 2 therapists in the room. Versus my other patient where rock solid and stable, really no history of any issue concerning safety issues, but had this traumatic event, now looks like they have a formal diagnosis of PTSD, have good family support, otherwise very stable. Maybe you only need 1 hour of preparation. Maybe you only need one person in the room with you during the medicine sessions, and maybe you only need 2 hours of integration. Yeah. Right. So I think I think that's where we're going to end up, or hopefully that's what we'll end up. But there are some people in the space who are going, look, this is early on, right? We're early on in this revolution, this renaissance. Right. Let's not blow it by having something untoward happen because we decided to skimp on the safety. Right. Let's maintain this full model, at least for 2 or 3 years. Right. Right. And then afterwards, when we have the safety data, maybe change the regulations around so that it can be a little bit more lax. Right. Now, the horse may be already out of the barn because the FDA can kind of do their thing, but a lot of states are already thinking about and moving towards implementing their own types of regulations or guidelines as far as how to regulate psychedelics. Right.
And it's state dependent. So one state might be really stringent, the other state might be really lax.
Yeah. And then that we may use that as a learning opportunity, right? It's like, look, you got some states that are adhering to the full model, right? And you got some states that are pretty lax as far as the therapy training and the therapy hours. Let's gather that real world evidence, and after a year, if it looks like there's a really unacceptable rate of adverse events with these kind of looser guidelines, then maybe we go, hey, at the federal level, we're going to say, this is not safe if you don't do it with full model. Right. Versus, looks like, okay, maybe a little bit higher rate of adverse events, but they're able to treat 10 times more patients,
right?
And maybe overall the benefits outweigh the risks.
Yeah.
So maybe we say at the federal level, hey, it's safe to do it and we change the label.
Yeah.
Recommend full model, but maybe you can do 50% of it in certain patient populations,
right,
and it'll be safe.
Right. Yeah. Case by case basis, disease specific or severity of disease specific. I think is going to be really important. Yeah. I also think a big bottleneck is psychotherapists that are certified in administering psychedelics or doing a session under psychedelic exposure. Yeah. And I think you're just going to have to ramp up the training, right?
Yeah, the training, and then I think certainly it is important to have psychotherapists who are experienced with folks who are under the influence of the psychedelic, right? And that you just have to kind of do it, right? That's not something that 20 hours of training is necessarily going to kind of prepare you for. Maybe you just have to pair up with somebody who's already a veteran at this and just kind of experience it yourself.
Yeah.
But there's plenty of interest in research where, okay, what if we take someone who's trained in our standard psychotherapies, right? Not specific for the psychedelics. Let's say it's just a CBT or a CPT or a prolonged exposure therapist. Put them in a room with someone under the influence of psychedelics, and they deliver their standard psychotherapy with some modifications here and there. And maybe that can be as safe and as effective as someone who has gone through this 100 hours of MAPS training. Right. So again, that's an open question.
Yeah. So we got 10 minutes left. I really want to make sure that we hit what you're doing.
Oh, yeah.
Right, yeah. So some of the research that you're pursuing, some of the things that you're trying to set up at UCLA. Do you mind just sharing some of that stuff?
Happy to share. So I'm going to talk about both the UCLA and the VA because I'm actually on both sides. And both sides are very interested in psychedelics. So in fact, both institutions, the West LA VA and UCLA proper, are looking into establishing psychedelic research centers.
Nice.
And so for the VA, it's the VAPREC. And then here we actually have two of our most senior investigators in the process of, I can't talk too many specifics about it, but really to look at psychedelics in the veteran population, because I think this is going to be one of the first places where it's going to be, if it's effective and it's safe, and the VA at the central level decide that it's the risks and the benefits make sense, that we're going to be offering this to our veterans sooner rather than later.
Great.
And so we're actively talking with sponsors on that trial. Myself, I'm working with a company called Midison. They're actually a company out of Canada, and they're working with Matt Johnson from Johns Hopkins, who actually has the first federally funded psychedelic research project, and looking at psilocybin for the use of in smoking cessation.
Right. Yeah.
And so here we're going to be conducting this trial in outside of Johns Hopkins. He's got multi-site. The company has multi-sites looking at psilocybin for treatment of smoking cessation.
Right.
And then over at UCLA, Charlie Grobe has an ongoing study, or is actually funding up for a study, for multi-site study looking at psilocybin for end of life. And so there we also want to build a psychedelic research center. We didn't mention this maybe a little bit earlier, but for those of you who have read How to Change Your Mind by Michael Pollan,
I'd recommend it.
Yes.
You recommended it to me.
Yes.
I started it. It's excellent.
Yes.
Highly recommend it.
Yeah, excellent writer. And UCLA is mentioned multiple times because back in the 50s and 60s, we were at the heart of all this, right? And so we're a little bit behind in terms of setting up our own psychedelic center, but I think with our history, our current expertise, leadership, and interest in this space, I think we're well positioned to really kind of be in the game. And so both the UCLA side and the VA side, we're looking for sponsors, funders, people who want to promote psychedelics in the veteran space, people who want to help build a psychedelic research center at UCLA. We're at the kind of starting points of it, and we're looking for people to come on board.
Awesome. Let me put you on the hot seat real quick. We have a few minutes left. Where do you predict in 20 years the use of psychedelics in medicine is going to be?
Yeah. So, I think it'll be beyond just mental health applications. So we didn't talk about this before, but there's evidence that there are potent anti-inflammatory properties for psychedelics. And for someone like yourself who works with TBI, acutely perhaps, the psychedelics, and maybe not in combination with the psychotherapy, but just the compound itself could be actually very beneficial. I really hope that in 20 years we'll be able to recognize we'll have recognized the utility of this model. So people keep talking about how do we strip down these current models to fit them within our healthcare system. So the question I kind of come back with is, how many times have you had somebody defend or talk about our healthcare system as being not broken, right? Like this, our healthcare model is like perfect. There's nothing to change, right?
Yeah.
So why
let's just fit all our practices within this perfect model, right?
Exactly.
That no one ever complains about. Yeah.
So why would you take something that works and fit it into something that's broken?
Great point.
Maybe we could learn something from why psychedelics works, this model, right? And incorporate those features into our healthcare model so that, it can more easily be distributed. Yeah. Right. Now, certainly, yes, we can't change the system overnight, right? Unfortunately, I'm not that optimistic. But I think, we should be humble enough to say, hey, maybe we should change something about our system, or maybe we should make modifications so that we can accommodate this, something that clearly works quite well, and really be longitudinal and future thinking about it. A lot of our healthcare decisions, both from the practitioner side and the payer side, are very kind of short-term and limited. And I'll just use an example. Antipsychotics for treatment of psychotic disorders. The long-acting injectables clearly work better, right? People stay on the medication, they do better on long-term, but they're very expensive, right? So the insurance companies don't want to pay for them. They say, take the pills, right? The pills are cheaper, right? Data clearly shows that they don't work as well as the long-acting injectables. But if you had the long-term mentality in mind, over the course of 5 years, patients who are on injectables don't go to the hospital as much. I'm going to recoup my investment in like 2 years, right? As opposed to just looking at this current fiscal year, my expenditures with long-acting injectables versus expenditures with the orals. So I think if we take that long-term vision, we have that long-term vision, I think we'll come to appreciate the benefits that the psychedelics offer. And really for all our patients, it's really about long-term, right? These aren't bacterial or viral infections that we're trying to cure over in 10 or 20 days. These are lifelong conditions. At least by the time they reach a mental health specialist like us, by the time we're considering something like a psychedelic, this is probably not a one episode type of depression. These are recurrent episodes. They have significant morbidity and mortality and functional impacts in someone's life. And just looking at just the economy in general, right? You look at the World Health Organization and identify depression as one of the most, I think, one of the top disabling conditions around the world, affecting people's ability to live and just really economies. If you think about it from that perspective.
Yeah, I think also, coming back to the veterans that you work with so closely, the risk, the rate of suicide in our veterans today per day is absolutely unacceptable.
Absolutely, I would use that word.
Absolutely unacceptable, right? And the fact that an insurance company wouldn't pay for something, or that a government or a healthcare system would try to, fit this sort of psychedelic therapy that could potentially be groundbreaking for these veterans that have sacrificed so much for us already. The fact that they would try to fudge with that to fit inside a broken system, that's also unacceptable. Yeah.
And even though I speak for the VA officially, I can say that there are folks very interested at the highest levels of making this current model available to veterans, so that if and when the FDA does approve it, that we can hit the ground running.
Awesome.
So it's very rare that when things are newly approved by the FDA that the VA incorporates them immediately, primarily for safety purposes, right? Because we don't know how they they're going to be within the veteran population. It's a unique population with a lot of comorbidities that you don't see in kind of patients with clinical trials. And so I can say that there's interest in ensuring that this is properly investigated, properly tested out, so that if and when it does get approved, that we can say, hopefully we can say on day 1 or day 2 after FDA gets its green light that, okay, we're going to be offering these to veterans.
Right.
So we are we're thinking about this.
Awesome.
Because this is something that is unique and up to this point really revolutionary.
Yeah,
so we can really hope that the veterans will benefit.
And just a last word from myself is, this is, like you said, revolutionary. And to be a physician, I'm kind of ancillary to this because I deal with a lot of TBI and there's concomitant mental health. So just being on the ancillary, this is so exciting. And one of the things that I look back and makes me so happy to have gone into medicine, the fact that I can actually be involved in this revolutionary process, either from an observation standpoint or possibly even clinical, right? It's absolutely incredible. Any healthcare providers, anyone that wants to go into medicine, any medical students, anybody, look at this, because this is one of the most, I think, the most exciting parts of medicine right now. I'm serious, 100%. Like it's right on the horizon of medicine in terms of what's coming. It's really exciting. It's incredible. And that's pretty much it. And even if you're not a healthcare provider or a medical provider, this is something that could potentially help you. And it's right on the horizon if you just kind of hold out hope. Right? Potentially this is right on the horizon. So, just hang on, hopefully a little bit more time.
Yeah, couldn't agree more. A very exciting time to be in healthcare and in psychiatry and in medicine in general.
Right, awesome. Thank you so much for coming. Any last words from you?
Again, I think the public's interest in this, I think, is really driving a lot of the momentum too.
Right.
And so, the more you become educated, or the general public becomes educated to know, the limitations, of course, of this, right? It's not going to be a panacea, unfortunately, right? But it can potentially help a lot of people. But I think to become informed about it, and I think this may be a gateway for folks to be to have a more open conversation about mental health. Because I think in this country and just even worldwide, just being able to speak about mental health on par with having a broken arm, I think that's ultimately our goal, and hopefully this will facilitate that.
Okay, awesome. Everyone, thank you so much for joining today. Thank you so much, Dr. Dunn, for coming on.
Thank you.
Hopefully you can come back and we can discuss what psychedelics demonstrate about consciousness. But that's for a later day. Thanks so much. Please, there'll be an email in the video description if you guys want to email us any questions. If you're interested in potentially supporting what Dr. Dunn's doing, shoot us an email and I'll put you guys in contact. Outside of that, that's pretty much it. Are you ready for some holotropic breathing?
Let's do it.
Let's do it. All right, everyone. Bye-bye.